call on folks to introduce yourself. So I'll look quickly to see if anybody is doing that. And while I look for that, Carolyn, go ahead.
Good morning. Yes, I'm Carolyn Grandon, the Associate Vice President of ICM at CHNCT, and I'm standing in for Lauren Williams today.
Great. Excellent. Anyone else?
I see Tiffany.
Hi,
Tiffany,
good morning, everyone. This is Tiffany Donaldson with the Connecticut Health Foundation.
Great. Thank you. Any other folks? And if people could just, if you could add your name and organization to the chat, it's just helpful for us to be able to just have a list of the folks who are able to join the session. And we will grab that as we go. So without further ado, I guess we can dive right in. Thank you, Tiffany. So we're scheduled for an hour today. So a little bit of a shorter agenda than our last session. We'll do a quick overview of our roadmap and timeline review, which we've looked at before, but just to give us a bit of a grounding. And then we are going to spend a majority of today's conversation talking about key outcome measures and targets by looking at preliminary data and the results of that data, looking at some methodology used to come up with some straw targets, and then looking at overall targets and gap closure targets by subpopulations. And we will wrap up with next steps. So if we can jump to the next slide, this should look familiar to those of you who have attended these meetings before. This is just a reminder of the different buckets of work that are going to go into creating the maternity bundle. And just here's where we are. We did a lot of work thanks to this group and a couple of other breakout groups around doula integration, and that work continues based on the feedback provided. And we will expect to come back for another session later in the summer to talk more about the doula integration. And as mentioned for today, we're going to be focusing on target setting for program outcomes. So next slide. Great. So this slide is really kind of a reminder for folks of the key outcome measures. It's around what we've talked about before. And you'll see the 5 outcome measures that we've talked about, but actually if you look in the box on the left-hand side in the table, there's one additional one. You may recall that we had a conversation in our last session around the NAS rate and the feeling that it was pretty narrowly focused on opioid addiction. So we now have included the overall NAS rate, and you'll see those numbers reflected here today. Our focus for the conversation today is going to be twofold. It's really around quantifying targets for each outcome measure. And as mentioned, we've built some straw targets based on the existing data. And really the intent here today is to have conversation in the group around, are these the right targets? Are they too aggressive? Are they not aggressive enough? And to gather feedback from all of you based on the expertise that you have. And then we're also going to look at the ways in which we need to look at closing the disparity gaps for each of the measures. And we'll get into more detail about both of those in just a few minutes. So we're going to start by reviewing the measures from the last 5 years and looking at what the projections are for 2022 based on the last 5-year numbers. And then the next thing we're going to move to is looking at how we'll reviewing how the team set the targets for reducing overall rates for the measures and looking at, are these the right measures or not? And then we'll wrap up by looking at the review of the data broken out by population and what would need to happen in order to start closing the gaps of disparities between those populations over the next several years. You're going to hear from several of our team members today. Angela, who is normally here from Faulkner, is out of office today. So we have a couple other folks from our team who are stepping in to help with some of the details, and those are Deb and Meryl, and we'll be introducing them in just a moment as they come in. But let's start by handing over to Tiffany for our discussion of the current rates.
Thanks, Carson. Before we dive into our overall targets, we wanted to start by grounding in the current data and trends that we're seeing for Connecticut in terms of the outcome measures that we've identified. So to start off, we looked at data from 2017 to 2021. And like Carson said, we projected forward 2022 rates based on historical trend. We started with 2017 because we recognized that from 2020 and onward, we would have some rates impacted by COVID. So we wanted to have a broader historical view of the trend in Connecticut. So going through this table, we'll see where Connecticut currently stands for our outcome measures. Starting off with the C-section rates, we looked at both the overall C-section rate and also NTSV, nulliparous term singleton vertex, or low-risk C-sections. Both of these rates are fairly similar, with the rates hovering in the low 30s. And when we look to the right orange column, we see the average annual trend rate, and we can see that for both overall C-section and NTSV, both rates remain relatively stable with change year over year. For adverse maternal outcome, we unfortunately see a different story. The rate starts at about 24% in 2017, but as you can see, it's increasing to 28% by 2022. So this is an example of a measure that we really want to impact through this maternity bundle and improve outcomes, as it's been increasing year over year. Looking next at our NAS rates, for opioids specifically, we are seeing an improvement in the trend. I'll call out that for both the average trend rates for the opioid-specific NAS rate and the overall NAS rate, the percentage trend may look a little bit larger, but we wanted to call out that the denominators for each of these rates are on the smaller side. So that is the explanation for that. Unfortunately, for the overall NAS rate, you can see that the trend is increasing here year over year. And then finally, we're seeing again, trends increasing in the wrong direction for NICU utilization, with NICU stays becoming more frequent year over year. And just to call out, in the notes section below, we include the definitions for each of these measures, so you could see specifically what the measures are looking at and how we are pulling that and grabbing that data. Before I pass this on to Deb, are there any questions about what we're seeing so far in Connecticut?
I see Amy put one in the chat asking about whether we have the sections separated by primary and repeat. I don't believe we have those numbers. I'm not sure whether that's a number that we would easily be able to obtain. I'm not sure whether anybody from the DSS team might be able to speak to that.
I don't think we have that data. I was just gonna say, I don't think we have that, unfortunately, in our easily accessible at the moment, just because I don't think it's captured by Palmata, or I think, Amy, you were gonna jump in.
Brad, I'm not sure, but we can certainly ask. I'm not sure how you can easily get the primary and the repeated C-section rates, but we can check with Csection and ask. I'm not sure whether that's something that we need to even check in the charts for. So we can ask for that.
I can jump in. It's Larry McGraw from Csection. Yeah, I think we would have a problem collecting that because the mom may not have been on Medicaid for her first pregnancy. So without looking in the chart, which, you know, it's very resource intensive, we may miss a significant portion if we only look at claims-based activity.
Thanks, Dr. McGrath.
Thank you. Amy, I see your hand is still up. I don't know if you have a follow-up question or comment.
Yeah, I just had a quick question about the adverse maternal outcome rates. That those seem really high to me, given what the definition has, and I'm just curious if there's a denominator error there. I've seen like severe maternal morbidity measures that are usually in the thousands, I think, is the denominator that's usually used. So any light you can shed on that would be helpful.
When we were looking at benchmarks for adverse maternal outcomes, we saw that some rates would either include or exclude hemorrhage. In this data, we are including hemorrhage, and the rates tend to drop significantly if you're excluding hemorrhage in the outcomes.
You happen to remember how hemorrhage was defined as far as 500 or 1,000 or some other definition?
I would have to look back.
Yeah. Okay.
Again, this is all claims-based data, so we have a specific code set. So it has to be captured on the claim, and it has to be coded as hemorrhage on the claim and to be included in the data set.
Got it.
And I'm seeing a couple additional questions from Bianca asking, it would be good to see the difference between obstetric rates and midwives. Again, I'm not sure how difficult it is to get to the difference there in the data, or if that's another requirement to look into the actual chart.
Yeah, I think there's some challenges with attribution depending on, since certified nurse midwives, we're mostly doing the C-section rates and how we're attributing that. But I think it's a good question to think about some of these things. So, and how we're actually going to capture them. So some of this is probably just recognizing some of this data is kind of for us to drive outcomes, if that makes sense. Obviously, the more we can disaggregate by obviously race, ethnicity, et cetera, better. We are obviously going to be interested in looking at some of this level at practice level in the future, but just recognizing that some of this will help us know if we're achieving our goals through, if that makes sense, in terms of the utilization of this in the future.
Great, thanks, Bren. Any other questions before we move on to the next slide? Okay, I think we can pass it over to Deb to speak to the next several slides.
Sure, and actually keep that other slide up for just one more second, if you would. And hi, I'm Deb Faulkner. I'm playing Angela Sherwin on TV today because she's on vacation. As you see here, the trends, I just want to ground you in this before we move to the next slide. So if you start with the 2022 projected, that's the starting point. And you can see from the history that most of this has been pretty steady. It's not jumping around. So it gives you some confidence using a 2022 projected as a baseline. And those baseline trends, which were, as Tiffany pointed out, either flat or somewhat increasing for the most part. You then go to the next page and say, all right, now the goal is to set some both meaningful and achievable targets for the program. And so those are obviously conflicting objectives. And how do you set that? And how do you set this in a reasonable way? And can we set goals that are both meaningful and achievable? And so what the team has done is start with the same starting point you saw on the prior page. So if you look at those same rates down the left side and the 2022 projected rate, which is the last thing you saw on the prior page. So for example, for overall C-section rate, you see that 2022 projected 34%. And you say, all right, I've got a historical trend, that same number we saw before of 0.1%, essentially flat. How do we set a target? Well, the first thing we looked to was benchmarks. And for C-section and NTSB, there are pretty good benchmarks out there. And so we said, all right, let's look to those benchmarks to set the targets. And so for overall C-section rates, the target was set saying, and oh, by the way, I should have said, this is a 5-year target. Let's look out 5 years. Let's say that by 2027, where do you want to be? And so by 2027, how about we set the target that says, let's reduce this number to meet the 2020 New England average rate. Let's look at New England average, excluding Connecticut. That's 30.9. Can we meet that in 5 years? That would imply a 3.5 percentage point reduction, which in order to do that, you've got to reduce on average 2.5% a year. So rather than being essentially flat, you'd be seeing a reduction of 2.1 percentage points a year. Now that's the method, that's just the math, but the baseline is let's just look at benchmarks. And we did the same concept for NTSV. And for those we used the 2018 Medicaid average rate and said, let's try to get from that 31.6 we see now to the Medicaid average rate in 5 years. That implies a 6.5 percentage point reduction. And that would mean you'd have to reduce 4.5% a year to get there. I see there's a question. Tanya.
Yes, I was wondering, are we trying to encourage a C-section, or are we trying to discourage a C-section?
I think the intent, the objective is to try to reduce it. Oop, there's a
Okay.
echo. And so it was currently at 34, and you want to get to 30.9, which is the average, the New England average excluding Connecticut. Does that answer your question? Any other? Okay, so
Yes.
go ahead. Go ahead.
Yes.
Great.
Yeah, I just so is the reason to bring the C-section rate down because of cost?
It's a good question. I think the intent is that C-sections tend to be tied to less strong outcomes for the parent and baby. So you want, and they're expensive. So others want to chime in on that, the intent of the C-section rate as a—
Yes, Tanya, I'm sorry, Tanya, would you mind? Okay, good, thank you. Yes, I was just going to chime in. Yes, Tanya, that's a great question. The primary goal for reducing C-section rate is to improve outcomes, because C-section, leads to complications, other complications when women undergo C-section, and it's also to decrease the disparity, because we know that in the data that Black women and women of color tend to get more C-sections compared to white women. So it is also to close that gap. And finally, yes, it would lead to some cost savings, which we can actually reallocate to provide women and budding people in Connecticut with the quality care that they deserve. Thank you. Brad, do you have anything to add?
I was just going to say, agreed with Fatmata, and just the goal, and just what C-sections are sometimes necessary. And so we obviously don't want to decrease necessary C-section. It's really those that are unnecessary. And if you look at recommendations by the World Health Organization, others, and you look at other countries, the United States C-section rates are typically some of the highest in the world, if not the highest. And so we're interested in bringing those down a lot, especially ones that are unnecessary, because we know that there are increased risks for C-sections for birthing individuals, and we want to see those go down. Obviously, we don't want to decrease necessary C-sections, but those that are unnecessary, which I think there's probably a large number that are, that's really what we're looking to drive.
Thanks, Brad, for specifying.
I understand you guys are saying you're doing more of ethnic groups, and what about weight? Because I know certain females that are overweight usually tend to have a C-section versus natural birth. So do we have the data for the weights? Is that maybe why the United States is so high, because a lot of our population is overweight?
I'm not aware if we have that data. Can Fatmata or Brad chime in on that? It's a good question.
We don't have great BMI information. Or, sorry, go ahead, Fatma. We have decent, we also have so as a non-OB or midwife provider, I'm sure some of the other folks on this will be more expert at answering a few of these questions than perhaps we are, but we do have some data weight related. It's not always the best because it has to be coded. So we don't actually have the clinical, we'd have to do either a chart review, or someone has to be coded as have a code of being obese or overweight to identify that. And I think Dr. Morosky may want to jump in and add some context here as well.
Yeah. So, well, Brad, I see some other hands up, and there was Dr. Canty first, and then Dr. Morosky, and then Karen. So I don't want us to overlook anyone.
Yeah, so I didn't see Dr. Canty's up, but if she's up first, go for it. And then.
Yeah, I've been monitoring the hands. So Dr. Canty.
Yes, thank you. I just had a question regarding cesareans because I wondered if you're going to capture primary versus a repeat cesarean. And you pretty much answered this question. And I think Dr. Morowski may add something to this because we know that there's cases where it is necessary. Are you going to capture, like, is there a way to capture the reason for the cesarean? And I don't think, just to Tanya's question, I don't think they would put obesity as a reason for cesarean. There would have to be an underlying cause, but I'll leave that to the OBs to answer.
Thank you, Dr. Canty. Dr. Morowski, you're up.
Thanks for having me, everybody. Good to see everybody today. So I think the research does support that obesity is an independent risk factor for cesarean section, but there's also some complications that are associated with obesity in pregnancy that sometimes also are predictors for cesarean section. But like Dr. Canty is saying, it's not its own individual indication for a C-section, just a risk factor. My thoughts on this a little bit around how to approach this and some of the language we're using before. And Brad, you brought up the word, I think, unnecessary. I think with ease of data collection and with an approach of benchmarking, I really like these numbers as an individual obstetrician and on sort of a public health statewide level, and also as somebody that works closely with the hospitals. Overall C-section rates are reportable. NTSV is recorded and reportable, and we can get our hands around that. When we start getting into all the other stuff, and I would join everybody for a full day conference around unnecessary, necessary, primary, repeat, breach, third bit. NTSV is nulla paris. So if a lady has a C-section on her third pregnancy, that doesn't get counted in NTSV. To me, I don't know, that feels a little worse when you C-section a mom who has had 2 prior vaginal deliveries. But anyway, I do think that these numbers are great benchmarks with a lot of good hard work we can do. I think in so many different ways, use these to try to see them come down for various different reasons. But I think that the work that's trying to be done here to try to get that granular data is going to either cause hospitals, birth registries, somebody to get into each chart. I think that's going to be really, really hard to do. And so I think for ease of what we're looking at, and just to say, I mean, I know so many people who don't like the term NTSV, and I'm like, well, listen, we all just use it though. Like, you don't like it, I don't like it, we all don't like it for the same reasons, but it is what it is. We can at least benchmark it, and a goal to see it go down. And there's so many different ways to approach that I think is actually great. And so I like these, that's my personal opinion. And I think it's going to give us some ease of ability, but while at the same time, it will be disappointing and not giving that like granular data.
Thanks, Dr. Morowski. Karen, you're up.
Yes, I just wanted to ask if this is the total measure set that you're considering for the maternity bundle. I don't, I don't see other outcome measures for the infant, and I also was thinking about process measures to make sure that. So, for example, when the numbers are this small, it may be difficult to disaggregate some of these measures by race and ethnicity. But if there were process measures about the practices efforts to move towards, best practices in embedding equity and birth outcomes, that would be helpful.
I think, and others should chime in, the intent is that there's also a quality measure slate that will be attached to the payment model. And that quality measure slate will likely have more things that the docs can directly impact, or the clinicians can directly impact around process. And so I would anticipate some of those measures being there. This is the overall, this is like the United Way thermometer of the program. These are the things that are at the end of 5 years, you would say, yeah, we were successful because.
Okay, that's really helpful context. I apologize if I missed that. And the only other thing I would say then would be some kind of patient reported outcome measure, because I do think an overall shift in birthing people's experience of care will give us a sense of whether or not some of those efforts to address racial disparities are working.
Appreciate that feedback. Oh, go ahead, Palma.
No, go ahead, Brad. I was just going to say thank you, but go ahead.
Yeah, no, I was going to say, I think we're very interested in the experiential component. I think one of our challenges that we face so far is finding evidence-based data collection methods for patient-reported outcomes specific to the totality of care. There is some, it seems like, that are coming out around the more hospital historic, right around the actual birthing experience, not just hospital-based, but birthing, rather than like the totality of the prenatal to. And so that's, I think, a challenge. So Karen, definitely welcome, and others, if there's specific ones that you're thinking it could be useful for this, I think it's something that we are very keen to think about. Obviously, there are also some challenges with collecting this and other things, but welcome input and thoughts about patient-reported outcomes and experience measures, specifically around this.
Thanks, Brad. Dr. Morosky just shared something in the chat. And Dr. Canty, did you have your hands up, or was that a legacy?
I was just going to pretty much say what someone just said about the experience too, because I think we could capture some of those reasons behind this dear experience of having that cesarean. And also, I think it's going to be complicated to capture, well, maybe not, but what type of complications happened after a cesarean. But I think that's getting a little more complex than what's being looked at right here.
Thank you, Dr. Canty. Amy, you're up.
Hear me? Hello. I know Connecticut has among the highest C-section rates in the country of all the states. I think we might be like 9. We're in the top 10. We also have among the highest malpractice insurance. It's been suggested to me from some provider groups that I can't expect the C-section rate to go down in their practice given the insurance. They thought it was a liability issue. And I wonder if there is a correlation among states with high malpractice insurance and higher C-section rates.
That's an interesting question. I don't know. I have not seen that myself, but it's something we can take back as a question for sure.
Yeah, and probably not something that DSS will definitely have a lot of impact on, but it's an interesting question.
Yeah, thanks, Amy.
Okay.
I don't see any additional hands up. Thank you.
Okay, so I just want to, before I move from here, because I didn't get to the bottom half of this. So the first two were very benchmark based because those exist and because the measures are consistently measured on, across the country. The others are a little less consistently measured and benchmarks weren't as clean. And so because of that, what the team has decided to do is say, let's just look back at your own history. And you know that all of these have been increasing over time, or most of them have. So what if you try to go back to the best you've been in the last 5 years and accomplish nearing or at your 2018 rate or your 2017 rate? That would mean for adverse maternal outcomes, that would take it from 28 to 24. For NAS overall, it would take it from 4.8 to 4.3. 3.3. And for NICU, it would take you from 8.5 to 6. Those felt like you've achieved them before. It's moving in the right direction instead of the wrong direction, and still requires reasonable amounts of improvement year on year. Thoughts on that approach or those specific measures? Okay. Hearing none, then if this is the, thank you.
I see a hand up.
Thank you, Karen. I see.
Karen.
This is just a quick question. I'm wondering if there's a way to annotate or adjust for, just because the overall birth numbers per year are relatively small, to think about how do you take out NICU utilization for things like congenital defects. And adjust based on a national benchmark or something like that.
Yeah, that's a fair question. Is there sort of data anomalies on an annual basis that you want to consider, or sort of take out exceptions so that your annual trends that you're holding yourself to, that may be that's something to take back. Brad and Fatmata, it might be something that we do as part of the measurement, not necessarily of the target setting, but something you could do to sort of review your performance against those targets on a year basis, adjusted and not adjusted, right? Is that what you're thinking, Karen, or are we thinking more than that?
No, I am always a proponent of having both unadjusted and adjusted numbers, but I also like the idea of just having a clear, sometimes the bar is too low when you use national benchmarks, but just for something like this that's so subject to year variation, I think it can be helpful. And just for example, if you look at race-based mortality data for infants in Connecticut, the Hispanic rate is either the best in the country or the worst in the country, depending on which year you're looking at.
Yeah. We didn't see that on the overall, but I think that's going to be even more of an issue on the next conversation we're going to have about the targets by race ethnicity, because I think that's where you're going to see the smaller population pool, the more volatility. Here, if you looked back to what Tiffany was showing a minute ago, the trends were actually pretty consistent year on year, which made us a little bit more comfortable. But I hear you. That's a fair question and one that we should watch for. So we'll take that back. Anybody, Brad or Fatmata, anything else you would add there? Okay. No. So I do want to go then and say, all right, if these are the overall targets, you could say, all right, I'm done. I've got targets year on year for 5 years. But what the team had asked us to do was say, well, we really want to look at this. And to Fatmata's point earlier, a big part of the goal of a lot of this is not just to reduce the C-section rate, but to explicitly address disparities. And in order to do so, you have to sort of break this down and understand first how you're doing on these measures for certain race ethnicity groups, and then how best to close the gap. And we have to acknowledge the data is not great yet. No one's data is great yet. Connecticut's no worse or better than many states. It's a challenge, but you got to start somewhere. And so I'm going to give the overview, and then I'm going to turn it over to Meryl Abrazizi on our team, who's going to speak to the details of the methodology. But the intent here is to say, let's break this down and start to create targets that don't just, cut across populations, but that are specific to populations. And so if you go to the next slide and you say, all right, if what we want to do is understand the starting point as best we can with the data that you have. And so as best as we could with the data that you had, we said, all right, what is the overall C-section rate broken out by race ethnicity? So for Black populations, for Hispanic populations, and for white populations with what you had. And because that starting point starts to identify the disparities that you may want to address. And so for some of these, there are very clear disparities that jump right off the page, right? So on overall C-section rate, you see overall it was 34%. For Black populations, it's 38. It's 11 points higher, percentage points higher. Similarly for NTSV, not as extreme, but still higher for Black populations. For the NICU utilization, substantially higher for Black populations. 10.2 versus 8.5, 21% higher. And for adverse maternal outcomes, same, substantially higher for Black populations. And so now the NAS rate is a little bit different because you do see the opioid NAS rate being higher for white populations and overall still higher for white populations, but not quite as extreme. And so you do see different disparities for different measures, but the ones that, sort of the overall C-section rate, the NTSV rate, the NICU rate do seem to be very clear disparities for Black populations. Any questions? Because then you could say, all right, how do we close the gap? How do you sort of say, I don't want to just reduce overall C-section rates by 3.5%. I actually want to reduce it more substantially for Black populations than so that I can reduce that disparity. And so that's the close the gap methodology that Meryl's going to speak to. But does this baseline data, does this starting point make sense? Any questions here?
And also just briefly going back, I saw Allison asked the question, I know Fatmata responded, do we have induction rate data C-section, and we wouldn't necessarily have that. It wouldn't without doing like a chart-based review, we wouldn't necessarily know that it's induction, it's not induction. Larry, feel free to correct me here, but I'm fairly confident in that without collecting that specifically.
Yeah, that's correct.
Thanks, Brad.
Oh, sorry, go ahead.
No, that's okay. If you're done, I see Karen. Karen has a hand up.
Yeah, just quickly, was there consideration of using disproportionality instead of comparison of one group to another in this chart?
I think we did it both ways. I'd have to look back again. Here's where you're going to catch me being the voice of someone who's out. But I'll check back on that. I know we've looked at it a couple of different ways. This seemed to more easily identify, sort of point out the disparities than the other methods we used. But I don't think there's a right answer to what you just said for sure.
And I see, Allison, you had a question about whether there are additional populations we could look at. You specifically called out Native American. We do have the data more stratified. The rationale with not including all of it was because the numbers were so small that it really was skewing the data quite a bit. And so it's with the reporting data being small numbers, it makes it a little bit challenging to break out into too many different groups. I don't know if anybody else wants to add anything more about that.
Just going to say, I mean, and just as Head Deb had said, in general, we are still looking to improve our race ethnicity data collection so we can improve the accuracy of this over time. And I'm hopeful that that will get better, but we still have some challenges with a large unknown population, unknown race ethnicity cohort that makes it harder to interpret. So, and so we still think it's really important to do this, acknowledging some of the limitations of the data, including small numbers for some of the smaller populations like Native American, though that's obviously a really important. And I think we're interested in all disparities, especially as we think about historically marginalized communities and how we can improve the outcomes that those communities have historically faced. And so the more we can capture those disparities, the better. I think we just want to make sure that what we're representing and showing is meaningful and doesn't skew data in one way or another at this point in time, though. And I see Mark, your hand up. I don't know if, or go ahead. Sorry.
Thanks, Brad. So I was wondering. So there are race ethnic related disparities, but there are also income related disparities. The communities that are predominantly covered by Medicaid have often multi-generational poverty, economic, social, environmental injustice. And so the question is, as a comparator, it didn't look like there was a consideration as to what is the case, sort of what's achieved in commercial populations. Not that necessarily, for example, C-section rates in commercial is the right standard, but as a point of reference and understanding the unique effects of the wealth gap, the racial wealth gap, and multi-generational poverty, it seems to me that looking at these statistics from a commercial perspective is worth doing. Medicaid generally nationally looks at things like access. How does Medicaid access compare to commercial and so forth? So I just raise that as a consideration.
Definitely. Thank you.
Thanks, Mark.
Okay. With that as a baseline, in terms of a starting point, I'm going to turn to Meryl to speak to the methodology of Close the Gap. Is Meryl on?
I am. Sorry, I was on mute. Thanks, Deb. Hi, everyone. I'm Meryl Abrazizi. I work with Deb and the team at Faulkner Consulting Group, and I did all the math on this that I'm going to walk you through now. So This slide brings us the approach for how we worked on this close the gap methodology, as Deb mentioned, for adjusting the overall targets by subpopulation. The idea is that instead of trying to move the outcome measure by the same rate across all populations, we want to move the outcome measures by higher or lower rates in order to close the gap between the subpopulation measure and the overall population measure. So there's a lot of data on this slide. A couple of things I want to call your attention to. One is the box at the bottom where we look at the percent of members by subpopulation by metric. You can see that for the first three measures, those are based on the mother's race, ethnicity identification record. And for the bottom three, it's based on the baby's. You can see that we have much better information in terms of identification of members for the mothers than the babies. And that being said, the measures where we have 75% of the population identified as unknown, these numbers can get a little fuzzier. They're still directionally useful for us to look at how we should focus our programs to try to close the gap. But I just want to call your attention to some of the issues with the data, just acknowledging that the data we're working with isn't perfect, but it's still getting us in the right direction. The other thing I want to focus, and this is called out in the box on the right here, is that setting the targets by subpopulation doesn't solve the equity issues, but it highlights where we need to focus in order to make greater or less impact on the different populations. Let me go to the next slide so that this we can see this graphically, and then I'll stop for questions. So this is showing the next 6 slides actually are all pretty similar. It's a graphical illustration of the close the gap method. We have one slide for each of the 6 outcome measures. So we'll go through this one in detail and then stop for questions, and then we can look at some of the differences in the other slides. This method is looking at, as Deb said, closing the gap 50% in 5 years. So if we can continue that, then that would mean that the gap would be closed entirely in 10 years. So the trend lines show the trend by subpopulation and how those would have to differ in order to close the gap. So if we start with the chart on the left, this shows the dotted line is the overall measure, overall across the entire population. The 3 other lines are for Black, Hispanic, and white populations for that same outcome measure for the data that we have. There is also, as I said, a big chunk of unknown population. We didn't put that line on the graph. It's hard to impact that population. The hope is that as we continue to get better data, the percent of unknown identified will shrink and we'll have more ability to impact. So as you can see on the left, what this shows is if we take the same target trend rate by population, all the rates go down, but the disparities continue even though the measure declines the same, for all populations. The idea is instead that we try to look at things on the chart on the right, where we try to impact the Black population rate more and say the Hispanic population rate less, so that we close the gap between the populations over the 5 years. So you can see just as a numerical illustration, overall, as Deb said, we went through the earlier slide, we want to reduce C-section rates by 2.1% per year. According to this methodology, what we really need to do for the Black population, because their rate's 11% higher than overall, we need to reduce the C-section rate for the Black population by 3% per year. We need to reduce it for the Hispanic population by 1.5% per year. So it gives us a sense of how much to vary the targets by subpopulation in order to get to a point where we can close the gap in the measures. I'll stop there for questions.
I get how these charts have all these numbers. I'm still stuck on why C-section is so bad. Is how far later in the slides do we get to a way of doing the whole bringing the numbers down? I know you're trying to bring the numbers down, but what is there a plan on spreading the word? Are we saying that C-sections are worse than natural birth? You know, like I'm just from a mother's point of view, and I had both my children as a C-section. I didn't have any, obviously I didn't have any complications afterwards, but I did have some complications prior, but I was just focused on having a C-section from the beginning. I knew, so I don't know if there's other mothers that, you know, they have their mind made up, and is it where it's going to be like, you know, the insurance isn't going to cover it unless it's necessary. Yeah, you know where I'm getting at? It's like, I'm stuck there right now. I know you're talking about all these numbers and the rates, and you're separating them by race, by subgroups, you're saying. But to me, it's just, it's like, it's something that the mother decides, and then two, the doctor decides that, you know, because you have the difference between an elective C-section or a necessary C-section. And these numbers are looking like C-section period, whether they're elective or necessary, or the doctor just convinced the patient. You know what I mean?
Absolutely.
Yeah.
Tanya, those are, I think that you've gotten to the meat of where we need to go. It's great to identify the numbers that need to come down, but the how is the most important piece of that. And certainly part of the doula integration work, I think, you know, I'll defer to Brad and Fatmata for further details, but I feel like the doula integration work is one of the places where we could see that. And there are probably several other places where we can build that into messaging and information going out to members.
Yes, thank you, Carson. And Tanya, we hear you. You know, you absolutely hit the nail on the head. And this is why we're actually taking on this entire initiative and trying to change the way we pay for care. It is to target the, you know, unnecessary, like Brad had said earlier. There are some C-sections that are necessary, but there are those that are really not necessary. And that's the area where we want to target. And we will be working with our members, educating them about what we're doing. There will be the doula integration, the breastfeeding supports, and there are a whole lot of other things that we're going to do to get us there. And I see where your focus is. How do we get these C-sections lower? And we'll focus on the unnecessary C-sections. Brad, I don't know if you have to say anything to add to that, but I also see that Cynthia has a hand up as well. Thank you, Tanya.
Yeah, and I was just going to briefly say, I think, you know, we want to be as evidence-driven as we can, acknowledging that. And I think Tanya specifically, you know, they're not wanting to say like C-sections are good or bad. It's just like, what are things that will improve overall the well-being of the birthing individual and baby. And that's kind of one of our drivers, as well as thinking about like quality and cost, which have to go into this. And then obviously a big focus on improving disparities with still keeping the individual the pregnant individual at the center of it and trying to improve their care. And I think ultimately that's, you know, we want to improve the health and well-being, which is part of the reason we've picked this target. And so for some individuals, I mean, we're never going to get a C-section rate to zero. That would not be appropriate or healthy. And I think that is definitely not the goal. It's just to kind of, again, reduce the unnecessary ones. And if you look at recommendations for, you know, people that don't have any reason to have a C-section, there's the ACOG recommends not having a C-section. And I think I would imagine most providers probably that on this call would agree that we probably do more C-sections than are necessary at this time. And that's a lot of the reason that we've chosen this and are focusing on this and trying to pay differently so that we can both improve quality, reduce costs to a degree. I think it's really quality and experience more than a cost reduction, though those things in some ways are related. But I'll stop talking and we can pass it over to, I think, Cynthia and Dr. Canty.
Yeah, thanks, Brad. Cynthia, you're up.
Hello, everybody. I just wanted to say that perhaps Tanya can join us with the other subcommittee doula group so that she could learn more about how one of the focuses that Fatmata did mention is that we are going to have doulas available as a resource and providing information and working with the birthing parent so that she can perhaps understand more fully the dynamics that we're discussing here, because that is the reason why we're doing what we're doing, is to focus on the birthing parent's preference and their overall good experience and their health. And I just wanted to invite Tanya. I don't know if she's already been invited or if she has the time, but we would really be able to glean more from her experience and as a member of the community, and also to just provide her with information and maybe some more in-depth answers to her questions.
Thanks, Cynthia. That's a great point. And when we send out those invitations, Tanya, I'll reach out to you personally and make sure that you're on that invite. I think we did it the last time, but you probably didn't have time to join. Dr. Canty?
Yes, and I'll be very quick. Because I feel like Tanya is making a excellent point, a very important point. And with cesarean it is very complex, the reasons behind it. I think that we need to know more about the numbers of what's behind these reasons for the cesareans. And I'm sorry if it was mentioned earlier, but I feel like what Tanya's saying, like something is missing. And if we don't really know the root causes, how are we going to move forward? Because I think cesarean data is important, but I also want to know about induction. I want to know about those rates, because I think there are differences in care that's provided. So I think these numbers are really supposed to help us get to what the racial disparities are, but we could decrease the numbers, but are we decreasing the racism that still exists in the care? And how do we capture that and show that that's being decreased? Because we could decrease the cesarean rates, but if Black women and other women of color are still not being treated well, they're not being, getting true informed consent, these other pieces that can lead to issues, or even having a cesarean and complaining of something and not being heard, those are things that could still be missed. So I understand what Tanya is saying. I know it's hard to really articulate, but I think we have to really, you could throw the numbers out there, but how are we capturing racism? Because I think that's the driving force to these disparities that exist.
Thank you, Dr. Canty, for making this very important point, and it is noted, and we're going to continue working at that. Mark?
Thanks, Fatmata. I'm not expert in this field, my expertise is more in bundled payment models. The thing that I'm taking away from this conversation, I guess, is C-section is not the biggest threat to the health and well-being of women of color or birthing moms generally. And so you wonder what it conveys from a prioritization perspective to have that at the top of this list. It seems to me if one of the foremost consideration is the well-being of moms and their children, that we should be leading with something like adverse maternal outcomes. And some of the other indicators like the opiate related adverse outcomes and so forth. C-section should be on the list, and there are complications and things that are not, there are complications that where C-sections might weigh into that, and the decision to do a C-section when it's not needed is perhaps an unnecessary risk. But it seems to me as a priority area, if our focus is on addressing longstanding gaps in the outcomes experienced by women, we should maybe rethink the order.
Thank you, Mark. Great point, and it is noted. I'll pass it over to Faulkner. Deb, are you done?
Sure. I know there's only, is this just an hour? So we're at 3 minutes left. I don't know that we need to go through each of these slides because the methodology is the same. I'm happy to do so. Does it end at noon? I'm sorry if I lost track of that. The meeting ends.
Yes, we end at noon, yes.
So I don't think we have to go through all of these. I'll just flip quickly. Meryl, let me take over for a second and flip quickly. They all do the same thing, attempting to close the gap. And hearing Dr. Schaefer's points, I don't, they're not in any particular order. these five measures are the 5 measures. They happen to be ordered with C-section first, so thank you for that. But they all do the same thing. So if you go to the next slide, it's NTSV, and the same methodology applies. On the right, you see that's closing the gap. You go to the next measure, the same methodology applies, not just a straight reduction in the adverse maternal outcomes, but a more targeted reduction for Black populations where the gap is the greatest. Same approach for all 5 measures. So I don't think we need to go through all of these, but you should know that's the approach, is to say where there's a disparity, close the gap in that disparity, so that rather than just overall reducing the trend, reduce it more substantively for those that are experiencing the greatest gaps. And there was no, as I said, no order intended in these measures, but we hear that consideration. Any thoughts and last minute thoughts? Because it's 11:59 and I want to be appreciative of everyone's time.
Just briefly, I know that a lot has been brought up around the quality metrics. So we have engaged Yale Center for Outcome Research and Effectiveness to build in quality metrics. They are focusing as much as they can on patient-reported metrics as well. So I just want to remind everyone that there is an overlay with some additional metrics that will be a part of this in totality that we are looking at, and the feedback is very helpful.
Yeah. Thank you.
Thanks, Tiffany, for highlighting that.
Okay, I'll turn it back to you, Brad and Fatmata.
I just wanted to briefly say, I think we greatly appreciate everyone's expertise and engagement. It's really well received. We are extremely interested in, I think, improving, fundamentally, especially the care for historically marginalized communities and racism and how that's impacted the communities, and recognizing that this payment bundle will not fix all of those things, but we hope it will help improve some of the care that is received, especially that is not historically, that where there is historical racism that's really even being brought into these encounters. Obviously, this is going to take some time, and this, even doing this is not an end all be all, but we hope is a first step towards driving some of this change. And so we are super appreciative of all of your time and expertise, and we look forward to continue to work with you. We'll take a lot of this feedback back, and we'll be talking about it internally. Faman, anything else as we wrap up?
No, just thank you everyone for your time and input. It's been great. Thank you.